C2AI, intelligent AI solutions to improve outcomes for patients, prevent avoidable harm and save money. So this is pretty fundamental stuff. Hospitals exist to save lives, make you better, not make you worse. Challenge is those things are actually very hard to measure, and I'm going to address those in a second. Firstly, just to give you an idea about the power of AI, we've been able to do some things, get our solutions validated, and along the way that's been recognized. So we are one of 10 essential digital health ideas for a COVID-19 response in the UK. We're a top 100 digital health company, and we're in the essential category, which is a jaunty 11 companies. Again, from a marketing perspective, top 10 would be better, but they've decided there were 11. We were mentioned in Parliament by a government minister as leading the way in health tech in the UK. And at COGEX, we're able to win the Health Tech for COVID-19 award and also the overall Tech for COVID-19 awards. And I'll explain really how we've been able to use the power of AI to deliver these solutions and to do good, to save lives, to make people better. So on here, the only quote I'll kind of refer you to is top left. That's Hassan Chowdhury, who is the stunning digital health lead at Healthcare UK and DIT. His estimate is that we could save £1 billion annually for the NHS and 70,000 lives just with one particular solution that I'll kind of outline to you. Now, the interesting thing here is there's natural tension between the ability to have a great idea and to deploy that. In the US, we're finding it very easy because people are very concerned about the bottom line. They've got plenty of issues to do with turnover at present. ER rooms are kind of empty at the moment. They're about 50% down on where they were. COVID-19 patients are not paying enough to keep the hospital running. They're furloughing staff. And of course, they've paused their elective surgery. And in places like Houston, they're going back into the kind of dangerous situation they were in a few months ago in New York. So we're trying to identify ways that AI can work. And what's interesting is that actually, if you can use this stuff before you get deep into a crisis, you're going to be better prepared. Because at the moment, from the top of the NHS, obviously people are super busy trying to sort out some fairly major problems, and at trust level, people are face down in the crisis. So it's one of these things where if we can start to get some forethought and really get people thinking about AI before the disaster happens, we'll make further strides in the future. So to give you an idea, one of the applications that we have prevents 2 avoidable conditions that you acquire in hospital. To give you an idea about how bad that is, hospital-acquired acute kidney injury, or HAAKI, 25% of people in ICU will have that in a normal period. In a normal year in the NHS, 140,000 people in the UK alone will die of acute kidney injury and hospital-acquired pneumonia, or 700,000 in the US. Now, what we're seeing, because we're present in 11 countries and we're monitoring hospitals based around what we've learned from our global data set, AKI is doubling to trebling in hospitals. Now, why that's so much of an issue is if we look at one place in New York, they have 36% of their COVID-19 patients have this condition. And the mortality rate we have in the UK is 28% for acute kidney injury. That means 10% of people who rock up into hospital with COVID-19 are dying from acute kidney injury, not from COVID-19 related symptoms. What we've been able to do is, in a hospital within a matter of weeks, by boiling down the AI learning and keeping the preventative tool up to date, we ask a series of questions when somebody arrives in hospital or when their condition changes. And that enables the hospital to figure out whether they're at high, medium or low risk of these conditions, hospital-acquired pneumonia, hospital-acquired acute kidney injury, and then set them on a right care path. So we'll actually change what's done with them to reduce the chance of them getting those conditions. Now, you could do the ultimate level of care for everybody, but then it's a huge resource drain. So this is about who needs the care, targeting that. That hospital, like hospitals in New Zealand, Sweden, and other parts of England, was able to reduce these by 50%. So 50% reduction in the whole of the NHS, that's 70,000 lives a year. In terms of capacity creation, which if we get to another surge again will be pretty important, that's 5 large hospitals running 365, 24/7, fully staffed for free, because this is just capacity that's in current hospitals you're already paying for that isn't available. Because an acute kidney injury patient, they will stay for another 6 days on average. A hospital-acquired pneumonia patient stays for an extra 8. So clearly in places like Mumbai, like Houston, where they're at pretty much a breaking point, if you can reduce these avoidable conditions, you create capacity for beds those beds can be used by patients that wouldn't otherwise have them. And if you have people being turned away who have COVID who need a bed, that is a death. So as well as the 70,000 patients in the NHS, if you went 12 months using this extra capacity, you would save an extra 150,000 patients if COVID-19 was virulent. 45,000 of those patients would find space in ICU. Now, it isn't the case in the UK. We're hoping not to return to that kind of severe pandemic, but in other parts of the world, this is absolutely crucial. So save lives directly from these conditions and create the capacity that people need. While saving in the UK £1 billion of direct costs, 12.5 billion of USD in the US. And the problem is these things, they have a long-term tail. So if you survive acute kidney injury, and only 72% of people do that, there's a decent chance that for a chunk of those, they will go on to have chronic kidney disease. They will go on to need dialysis or transplantation. Now, we're pretty lucky in the West. We've got decent facilities for those. Now, those are going to get stretched in the future. But if you go to Italy, you've got 85 kidney specialists, nephrologists per million population. If you go to India, you've got 8. If you go to South Africa, you've got on average less than 1. So in these countries where COVID creates this long tail, they don't have the infrastructure to cope in the longer term. So there's literally tens of billions of dollars of extra cost going to be required to keep these patients alive, or we're going to see significant long-term deaths in the tail from COVID-19. So what we're doing essentially, we have 140 million patient records drawn from 46 countries. We have access to the NHS database. We have full access to that. I think there's 6 companies in the UK that have that, and that means we get audited to within an inch of our life 2 days every year. We're ISO 9001, 13485, 27001, NHS digital approval, MHRA approval, pretty much everything that you need to do this and show that we do this in an ethical and a responsible fashion. We've created algorithms that we then use in a variety of ways, either retrospectively to identify in a hospital where they have issues on performance, or these preventative type apps that I just mentioned to you. But what we're able to do in a hospital, rather than just doing simple measures of the number of complications, say, we can actually identify with the case mix of patients who should have had a complication, who shouldn't, aggregate those up and identify in the hospital where the issues are and how to help so that they save lives, save money, and reduce harms that are done. So some pretty solid benefits. Now, the top here, Institute for Healthcare Improvement says that hospitals should have a set of metrics that reflect meaningful outcomes. Well, your local hospital doesn't. Your local hospital measures mortality as a percentage of the number of patients through the door. That's crap, basically. So in New York at the moment, we've got New York Presbyterian who are seeing a massive surge in COVID-19 patients. Their mortality is up significantly. Are they doing a good job or a bad job? Intuitively, you know that because of the case mix of patients, because of these COVID-19 patients coming through the door, it's not that they're doing a bad job. The world's just changed around them. So the top screen is the raw mortality rate, top table, showing from a real hospital what their raw mortality rate was as a percentage of admissions. So at point A, they're thinking we're pretty bad. At point B, they're thinking we're not as bad at A. It's going slightly wrong, but we're kind of okay. We do the individual risk adjustment with the AI tuned algorithms to figure out what should happen. And we work on this thing called an observed to expected ratio. If it's less than the observed to expected ratio, i.e. less than 1, things are good. If it's more than that, there's a problem. At point A, using that individual assessment to reflect the case mix of patients that they have in that hospital, they were fine. Not great, but they were fine. They were at 1. At point B, they've gone to 1.5, which in my world is really, really seriously bad. So if you imagine that you're just trying to run the hospital by the top information, you don't know when things are good, you don't know when things are bad, and you can't fix those things. So we're providing insights to hospitals that enable them to radically change the way that they work. In line with that, we're able to spot 90% of the avoidable harm and mortality and variation in a hospital that their current monitoring systems can't use. And I am desperate to get my local hospital to use this. I sat with one of their senior people recently and mentioned that being quite old and near to death, I'm going to be in there fairly soon, and I would love them to be using this system for purely selfish reasons. This is where I go, this is where my kids go. So we're trying to kind of fight the good fight with the NHS, but we're actually finding it somewhat easier abroad. We're in 12 trusts, but it's still a wee bit of an uphill challenge for health tech going into the NHS. And some of you are kind of nodding vigorously at this stage at the other end of the camera. So another part of COVID-19 is that we know we're going to have this massive backlog of patients. We're going to have 10 million patients hanging around waiting to get their surgery. So one of our other products is called Compass Preoperative Risk Assessment. It's a fantastic marketing mouthful. What it does is it says, look, you're an individual. Rather than giving you a leaflet when you have an operation, we're going to figure out what your real risk of mortality and real risk of complications are. Now we can do this on an individual basis. So I am quite old. If I had a radical laparoscopic prostatectomy, my risk of mortality is 1.6%, assuming that my key physiological variables are normal. Give me low sodium and my risk of death is now 5.2%. Give me low sodium, low blood pressure, my risk is 15.2%. So good luck across the 5 to 10 million variations of operative type and key physiological variables that we know because we've got the world's biggest and most geographically dispersed data set. Good luck figuring out who should go first or second or third from the hundreds of people on this webcam or the millions of people on the list. We can do it. We basically bulk load the whole elective surgical list into our system. At the bottom there's a table which kind of indicates the type of information we have pre-sorted. We'll do work on the risk of mortality, risk of complication. We'll enable doctors to also click through to the individual lists of information that, as we see in that PDF on the right-hand side, which shows the complications that are most likely to happen, so that when you have an operation, the staff can talk to you and say, actually, chest infection is quite an issue. Get up and about on the day of the operation. We'll manage your pain relief, but please play ball with us. Motivate you to be part of your own care and your own recovery. Also, there's a massive cost for the NHS and other health systems in what's called informed consent. If I wave a leaflet at you and say, you know, you'll probably be okay, that's not informed consent for you to sign up for the operation. If I give you a piece of paper that has your detailed risk of mortality and complication on there, as well as having positioned you in the correct point in the prioritization of the list, I can give that piece of paper and you sign it, then the NHS has got no chance of being sued for the lack of informed consent. Anyway, that's a little jaunty look around. My details are there. Please feel free to get in touch and ask any difficult questions. And there's